Immunotherapy and targeted therapies have improved survival rates for patients with non-small cell lung cancer. Benefits from current treatments in the first line are limited, and many patients experience disease progression. Primary and acquired treatment resistance pose significant challenges, highlighting the need for new treatments in non-small cell lung cancer. TROP2 is a transmembrane glycoprotein involved in tumour cell proliferation, metastasis, and survival. It is highly expressed in many epithelial tumours, but remains low in normal tissues. This makes it an ideal therapeutic target in non-small cell lung cancer. Antibody-drug conjugates, or ADCs, use monoclonal antibodies to deliver cytotoxic payloads to tumour cells, sparing normal tissues. TROP2-targeting ADCs bind to TROP2 overexpressing tumour cells and are internalised, releasing a cytotoxic payload. This leads to DNA damage and cell death. The released payload can also penetrate and kill nearby tumour cells, even if TROP2 negative. TROP2 targeting offers an exciting novel approach for treating non-small cell lung cancer. However, to effectively integrate TROP2 targeting ADCs into treatment plans, clinicians must understand clinical trial data, manage side effects, and select the right patients to optimize outcomes and ensure treatment success.
Okay, so we can start the symposium navigating the clinical impact of TROP2 targeting in non-small cell lung cancer. With me are Jarushka Naidoo from Dublin and David Planchard that is coming from very far, so from Paris. So this is a CME program, and these are all the information that you can find. Here are all our disclosures together, and we can go on the learning objectives that are assessing the efficacy and the safety profiles of TROP2 antibody-drug conjugates compared to the standard of treatment in non-small cell lung cancer, evaluate the utility of measuring TROP2 expression levels and in non-small cell lung cancer and the specific patients populations included in clinical trials to determine the eligibility criteria for TROP2 target therapies, and develop evidence-based management approaches for specific TROP2 targeted ADC toxicities in non-small cell lung cancer. So just to test the polling questions, so you can scan the QR code and ask how confident are you in understanding the potential role of TROP2 antibody-drug conjugate in non-small cell lung cancer treatment. And you can go from very confident to not confident, and then we will re-ask the same question to the end, and of course, all of you will answer very confident. So you can vote. Okay, it seems that we have to convert the neutral and in the somewhat confident or not confident in very confident at the end of all the presentations of from our estimate colleagues. Now there is another question. Maybe you have already seen the video, but what is TROP2's primary function in non-small cell lung cancer? Is a DNA repair protein? Is a ligand for immune checkpoint inhibitors? Is a growth-promoting glycoprotein overexpressed in tumors? Or is a tumor suppressor inhibiting cancer cells? Okay, good. It seems that we can go home. Okay, TROP2 is overexpressed in multiple solid tumors, and in particular in lung cancer is overexpressed both in adenocarcinoma and also in the squamous cell carcinoma, so rendering lung cancer one of the most important tumors for the application of the TROP2 antibody-drug conjugates, but you can see that this is not the only one. Also cervical cancer, prostate cancer, breast cancer are overexpressed. So this can really represent a great opportunity for the treatment of our patients, and we have to define which is the best algorithm to treat them. I just want to tell you that there are many antibody-drug conjugates in the development. Not all of them are the same. Some of them must be internalized to be active. Some of them don't, and they can be active just through the bystander effect. There are only 5 that have ongoing phase 2, phase 3 trial in resectable non-small cell lung cancer, and 10 are ongoing in the metastatic setting. The most advanced that we have seen are sacituzumab govitecan, the topomab deruxtecan, called also Dato-DXd, and also sacituzumab tirumotecan. And the key questions now are basically how to assess the safety, select who are the right patient for this kind of drug, and also who are the right patients for each one of them, because as I told you before, they have all a different mechanism of action. And then we have to focus on the safety of these drugs and also find the algorithm to manage the safety for these patients. After this introduction, it's my great pleasure to introduce you an expert and a friend, Professor Jarushka Naidoo. She is coming from the Beaumont Cancer Center in Dublin, and she was previously in Johns Hopkins in the United States. So it's my pleasure, and
thanks, Marina, for that kind introduction. So really a privilege to walk you through some of the key clinical data that really underscores, I think, the potential and the current clinical impact of TROP2 targeting in non-small cell lung cancer. So taking a big step back, where are we with lung cancer in terms of selecting the right patients? How do we think about patients with newly diagnosed advanced lung cancer? So the first step, of course, we have our friendly neighborhood pathologist who will separate our lung cancers into adenocarcinomas and squamous carcinomas. And from there, it is standard practice for all lung cancers to undergo comprehensive genomic profiling to identify actionable genomic alterations that may set us down a path of targeted therapy. For those patients in whom an actionable driver alteration is not identified, these are classified as non-AGA, non-small cell lung cancers. And from here, we would then do PD-L1 testing. And of course, patients will then be separated into those whose tumors are PD-L1 high, PD-L1 intermediate or low. And we see here then, we have options of IO monotherapy or IO plus chemotherapy. And of course, there are various different options with respect to combination approaches here. So what is a little bit of a shift in paradigm when we think about the antibody-drug conjugates is they really have the potential to deliver a targeted therapeutic approach in both the AGA positive and the non-AGA non-small cell lung cancers. So this sort of flips the paradigm on its head and helps us to separate the 2 different sets of data that may link to 2 different patient populations. So as Marina already mentioned, TROP2-targeted ADCs have now come to fruition with several phase 3 clinical trials in pre-treated advanced non-small cell lung cancer, and we'll walk through some of those and some of the associated agents. So the first, of course, which we've learned from our breast cancer colleagues, is sacituzumab govitecan. And in the lung context, this was first evaluated in the EVOKE-01 clinical trial. The anti-TROP2 monoclonal antibody ADC construct here, sacituzumab, the payload is a camptothecin payload, SN38, with a hydrolytic cleavage linker. So we always want to look at the payload, the type of linker, and then this assessor of the potency or intensity of an antibody-drug conjugate called a DAR. And here we see that the DAR, the drug-to-antibody ratio, is 7.6, which indicates this is quite a potent antibody-drug conjugate. The second we're going to touch on, which has been evaluated in the TROPION Lung-01 and TROPION Lung-15 clinical trials, is datopotamab deruxtecan. This has a different payload, an exatecan derivative, an enzymatic cleaver as the linker, and a drug-to-antibody ratio of 4. And the third that we're going to talk about is sacituzumab tirumotecan, which again has a different payload and a linker molecule that works slightly differently with both an extracellular component that is pH sensitive and an intracellular component. So a little bit more of an advanced linker structure here. Again, quite a potent compound with a DAR of 7.4. So starting first with sacituzumab govitecan. This was evaluated in a phase 3 clinical trial called EVOCO-1, which we heard as an oral presentation from Luis Pazarez, followed by publication. So in this EVOCO-1 clinical trial, this evaluated 603 patients with advanced non-small cell lung cancer and included patients who had actionable genomic alterations as well as those who did not. 73% of the population were non-squamous. And what we saw here was that unfortunately the primary endpoint of the clinical trial was not met. The primary endpoint in this case, overall survival, and we see here a hazard ratio of 0.84, where there was a very minimal difference between the sacituzumab govitecan and the docetaxel. Other secondary endpoints, we saw a very minor difference in median progression-free survival, objective response rate somewhat similar, maybe a little bit less, and then very similar grade 3 treatment-related adverse events, however less discontinuation rates from the sacituzumab govitecan. Was there any differences in terms of histology? Does this help us to select which patient may benefit from this approach? So we see here that really quite similar outcomes in both non-squamous and squamous non-small cell lung cancers, perhaps a numerical improvement for both, but of course these were not statistically significant and crossed the confidence interval threshold. Moving on to Dato-DXd. So this was evaluated in the TROPION-Lung01 study presented on the European stage a couple of years ago, again evaluating around 600 patients with advanced non-small cell lung cancer with and without AGAs. Very similar, 74% of the population were non-squamous. In this study, again, we saw that in this study, there were dual primary endpoints. However, there was a small benefit in terms of PFS with a hazard ratio of 0.75, and this equated to a difference of 4.4 to 3.7 months in median PFS. However, there was no difference in terms of median overall survival. Secondary endpoints of note were objective response rate, and we saw that there was an improvement with Dato-DXd compared with docetaxel with respect to response. Some high-grade toxicities related to this agent and discontinuations, but still favoring the ADC as compared to docetaxel. Asking the same question, is there a difference with respect to histology, this time for Dato-DXd? And this is where I think we see a little bit of differences coming. So we see here that the non-squamous non-small cell lung cancer population appeared to have a little bit more of a difference. Hazard ratio of median progression-free survival, here 5.5 versus 3.6 months, hazard ratio of 0.63, and again, no overall survival benefit. Less convincing in the squamous population. We see here that actually squamous patients did not benefit from Dato-DXd. And from the presentations, we do see that in this population, there may have been some particular safety signals which might have indicated a difference here. What about Dato-DXd for patients specifically with actionable genomic alterations? This was the topic of the TROPION-Lung05 study. This is a phase 2 study evaluating 137 patients in a heavily pretreated population, where most patients had greater than 3 lines of prior therapy. In this study, we see that patients with EGFR mutant lung cancer appeared to respond to this treatment with a 43.6% response rate, smaller number, but still some responses in the ALK population. And overall, in the intention to treat population of AGAs, there was about 35% of patients had some response to treatment. We also saw quite a favorable median overall survival. In a heavily pretreated population, particularly EGFR, median overall survival of 18.3 months is certainly something that we would see as favorable. And of course, these results led to breakthrough designation in the EGFR mutant population for advanced non-small cell lung cancer in December 2024. So moving on from here, so far, even at this meeting, we've seen that the landscape of EGFR mutant lung cancer is rapidly evolving, and that combination approaches in EGFR mutant lung cancer appear to be something that we will be seeing more and more, and may in some instances actually now become a more accepted standard of care. Such a combination that has been evaluated was in the Orchard phase 2 clinical trial presented just 2 days ago by Dr. Ming-Ju An. Here, the median follow-up was 14 months. We saw it was evaluated in 69 patients at 2 dose levels, 4 milligrams per kilogram and 6 milligrams per kilogram. And what we saw was that patients who are on the slightly lower dose appear to have a benefit in terms of, or a more favorable objective response rate. But of course, some grade 3 treatment-related adverse events that we have to keep a very close eye on, and particularly that these appear to be dose-related. Moving on to the last compound, sacituzumab tirumotecan. This was also evaluated in advanced non-small cell lung cancer in both patients with and without EGFR mutation. So we see in this trial, this was a phase 2 trial evaluating a smaller number, 43 patients. This separated patients into the EGFR wild-type population, median third line of treatment, and the EGFR mutant population who had progressed on or after a standard first-line TKI. And what we see here is we can see some responses really across the board, but again, quite similar to what we see with the other agents, that perhaps the more impressive response is seen in the EGFR mutant population here, with about 60% at a 60% objective response rate, median PFS of 11.5 months, and a median OS of 22.7 months. But even the entire population, which was heavily pretreated, a median overall survival of 22.6 months. And this now has underscored several global clinical trials in the phase 3 setting, which we can see here. So in summary, these are the clinical trials now that are taking some of these compounds forward into both earlier stages of disease and even in the first-line setting. So for sacituzumab govitecan, we have EVOKE-2, EVOKE-3, and the Velocity Lung study. For datopotamab deruxtecan, we have a series of the TROPION studies as well as the AVANZAR study, and then the TROPHY-007 study for sacituzumab tirumotecan. Looking specifically at the efficacy of sacituzumab in the first-line setting, this is the topic of the phase 2 EVOKE-02 study. So we have seen data with this combination in the first-line setting. Are we likely to see ADCs transform first-line? So in these 92 patients, we have seen that there again is some benefit with respect to histology, a little bit higher response rate in the non-small cell lung cancer non-squamous population, and a signal maybe that tracks with PD-L1, where the high PD-L1 expressors appear to have a greater objective response rate. And this is also associating with a benefit in median progression-free survival. I think, of course, a note of caution. The incidence of grade 3 treatment-related adverse events, something to keep an eye on here, 86.4% for sacituzumab govitecan. Docetaxel, of course, still high as well, but something really to keep an eye on, I think, with this entire class of agents. Efficacy of Dato-DXd in the first-line setting. This is the topic of the TROPION Lung-02 study. We have some data from the phase 1 clinical trial, and TROPION Lung-04, a phase 1b clinical trial. We've seen here again that we need to keep an eye on the toxicity profile, but again, we see a benefit in objective response. In this clinical trial, TROPION Lung-02, Dato-DXd is added to Pembro plus platinum doublet chemotherapy, so quite an intensive regimen. The triplet regimen, however, associated with a benefit in objective response, 56% for the PD-L1 less than 50%, 53% for greater than 50%. So really take-home message that there appears to be efficacy regardless of the PD-L1 expression. And we can see here some of the benefits in both objective response rate and disease control rate seen in TROPION Lung-04, which is expanding this further. So in summary, where are we now? We have seen across these range of phase 3 trials, as well as some of the emerging earlier phase trials, that really there is efficacy for TROP2 ADCs in previously treated advanced non-small cell lung cancer. And it will be our job as the oncology community to try to understand which patients may benefit more from this approach rather than others. Patients enrolled in the clinical trials were unselected for TROP2 expression, and certainly this is an area of innovation that several of these agents are exploring. Will a biomarker-directed approach help us to select patients appropriately? I think it is important for the field to watch this space. There are promising early data in the first-line setting incorporating TROP2 ADCs as a combination. Will we see greater benefit for first-line, or do we think that TROP2 ADCs have a better home in second-line? I think this is also a topic for further discussion. So this moves us to a polling question. It will be great if you can reply. Which patients with advanced non-small cell lung cancer are least likely to benefit from treatment with TROP2 ADC, such as Dato-DXd? Patients with, is it A, EGFR mutant lung cancer progressing on prior TKI? Is it those with squamous histology? Is it those patients with a positive QCS and emerging a biomarker for TROP2 ADC, specifically Dato-DXd, or other AGAs? Okay, everyone was listening. Good sign. So certainly we did see a signal that squamous may not be a group of patients that benefits as much from this approach and may have a safety signal of concern. So definitely something to keep an eye on. And any questions, please link to this. With this, I'm very happy to hand over to the next speaker, Professor David Planchard.
Thank you so much. Thanks for this excellent overview about the TROP2 and the exciting data about this population. I would say for sure nowadays what is missing and the piece of the puzzle is a biomarker. How we can select patients, except we can have this histological selection and probably actionable genomic alteration in the EGFR population. That seems to be probably one of the best populations to be targeted with datopotamab deruxtecan. But what about the role and the prognostic role of TROP2? So the first polling question, what is the prognostic significance of TROP2 expression in non-small cell lung cancer? Indicates poor survival and aggressive disease, limited prognostic value, predictive for therapy, no prognostic or no predictive significance, linked with improved survival outcome. Please vote. What about the role of TROP2? Okay, so it seems to be not prognostic, not predictive, poor survival and aggressive disease. I think we can discuss, and I think this is probably the right answer to this question that we have nowadays, mainly with retrospective analysis. So let's move. As you have seen, it's probably an excellent target for the ADC because you have this overexpression in most of the tumor types, including non-small cell lung cancer, and particularly included in squamous non-small cell lung cancer. Nearly 60% of patients with a squamous have an overexpression of the TROP2. In adenocarcinoma, it's around 50%, so slightly higher in the non-squamous if you compare to adenocarcinoma non-small cell lung cancer. So what we learn? What we learn about the role and the link about the pathology of TROP2. So it's just summarized. Generally, it's appeared to be linked to a higher tumor stage, mainly male versus female, larger tumor size, TP53 mutation, higher histology grade, and lymph node metastasis. So it seems to be related to a more aggressive disease. But what about if we go deeper in detail, and particularly looking at the prognostic role? So I will divide it adenocarcinoma versus squamous non-small cell lung cancer. It's mainly retrospective analysis, so we have to take by cautious. But you can see in these two different trials that look mainly in metastatic non-small cell lung cancer, adenocarcinoma, it appears that patients with a TROP2 high-level expression by immunohistochemistry have a worse prognostic in comparison to patients with a low expression of TROP2. However, we should take by cautious. If you take early stage, it seems to be the opposite. Patient with a high TROP2 expression seems to do better in terms of overall survival in comparison to patients with a low TROP2 expression. So again, we should look at which stage we are talking for. And again, it's mainly retrospective analysis, small cohort data. So keep in mind to be prudent. What about the EGFR? The EGFR is probably something really interesting. You have seen potentially the huge benefit of TROP2 and particularly datopotamab deruxtecan in this population with an EGFR mutation. It's probably one of the most important populations of interest with a high expression of TROP2 and particularly high activation of the TROP2 receptor after exposure to EGFR TKI like osimertinib. Same, we have to be prudent. You can see the first clinical trial, retrospective, it was clearly shown a high expression of TROP2 in patients with an EGFR mutation, and this population, TROP2 positive, highly positive, EGFR mutated, seems to have a worse prognostic in comparison to the other population. But in another clinical trial, included early stage, advanced stage, it seems to be the opposite. Patient with a TROP2 high, EGFR mutated, have a worse prognostic in comparison to the other population, TROP2 high, but EGFR wild type. So again, keep it by cautious, the interpretation of all these clinical trials. So that means it seems in the majority of the trial to be prognostic of a worse prognostic if you have a high expression of TROP2, particularly it seems to be higher expressed in patients with an EGFR mutation, but clearly it's not confirmed, particularly in prospective, clean data, clinical trial that clearly looked at the prognostic role of TROP2 in adenocarcinoma. What about squamous non-small cell lung cancer? If you look the prognostic role in the different clinical trial, again, retrospective trial, but it does not seem to appear to have any role in terms of prognostic value, whatever high or low. You can see same overall survival in both situations. Whatever, it seems to be associated with tumor with higher grade in terms of stage. In this population, if you compare the high versus the low, it seems to be also according stage and the grade of the disease in squamous, not prognostic, according to the stage, according to the grade of the disease in the squamous non-small cell lung cancer. So this is what we have nowadays in the squamous. You have seen in terms of prognostic role, it's not so clear. You can predict better or worse prognostic in terms of overall survival, mainly in advanced stage, mainly with higher stage, and mainly with a more higher grade of disease in squamous non-small cell lung cancer. What about the role potentially as a predictor of resistance to immunotherapy? TROP2, we don't know exactly the role of TROP2. We know it can be included in the MAP kinase activation, but probably also it can have a role as an activation in the T cells and potentially CD8 activation on the cell surface. It's not so clear, but it's a nice trial that look in two prospective cohorts that randomize atezolizumab versus docetaxel. It's a retrospective analysis, but it was done on around 900 non-small cell lung cancer previously treated, so that receive either atezolizumab or docetaxel. And what have been shown, if you look the TROP2 by mRNA, it was associated with a worse prognostic in patients that receive atezolizumab, which was not the case in patients that receive docetaxel. So seems to be predictive resistance of atezolizumab in this cohort. But the most important, they look particularly the expression of TROP2 on the cell surface, but also TROP2 intracellular expression of TROP2. And clearly, we need to look at the activation of the TROP2 receptor. And in this case, particularly if you look on the right, PFS, overall survival, intracellular expression of TROP2, it seems if you have a high TROP2 intracellular, you are more refractory with atezolizumab in terms of PFS and also in terms of overall survival. So the intracellular expression of TROP2 potentially might predict the resistance to immune treatment like atezolizumab in this retrospective analysis, but was done a huge number of patients. So clearly, biomarker is the key, except histological type, except EGFR mutation. Can we do better to have a specific biomarker to select patients that might benefit or not benefit with an ADC that target TROP2? So you have nowadays two nice trials, one prospective and one retrospective analysis. The first trial, the Icarus trial, that I had the pleasure to coordinate at Gustave Roussy. It was open in 10 centers in France, already presented at last ASCO meeting, and you will see also the key sales that was presented by Marina at the last World Lung Congress in the TROP2 Lung-01 trial. So the Icarus trial, it's only a trial that tries to identify on fresh tissue biopsy, multi-biopsy, sequential biopsy, biomarker in patients that received datopotamab deruxtecan in second, third line of treatment. So we did biopsy, fresh biopsy at baseline, we did biopsy on treatment, and we did biopsy at disease progression. We had a huge planned work on different biomarkers, look at the TROP2 expression by immunohistochemistry on fresh tissue biopsy, which is not the case in most of the trials for which they are looking the TROP2 in archival tissue biopsy, and I think this is an issue. We look at the gene expression by RNA sequencing. We also tested the TROP2 spatial distribution, particularly the intracellular activation of the receptor, modulation of the immune cells. We look also mutation baseline and mutation at disease progression, and also for sure look at the CTC, ctDNA, and multiple other biomarkers. So we still process the result of this trial. 100 patients have been included in France in this trial. Just to show you about the immunohistochemistry on fresh tissue biopsy, TROP2 expression, what have been shown, patients with a moderate or high expression TROP2 did better in comparison to patients with a low or negative TROP2 expression, which was not shown until now in the previous trial because it was done mainly in archival tissue biopsy. So potentially, we might use immunohistochemistry, but we might use it probably with a good and fresh tissue biopsy and need to be confirmed in further clinical trial. The other biomarker that was showed by Marina at the last World Lung Congress, they particularly look at the activation of the TROP2 expression. They look expression on the membrane and particularly intracellular expression of TROP2. They did a computational pathology approach, and you have a whole slide for each disease, for each tumor, and they look particularly cell by cell. So you need to have artificial intelligence to look and to evaluate the ratio on the membrane and the cytoplasm. Lower is a score, higher it means that you have a high expression of TROP2 in the cytoplasm. So they did QCS positive, that means high intracellular expression of TROP2 versus negative QCS. And in this case, if you look in the TROPION-Lung01, according to the QCS, in the whole population, you can see that patients with a QCS positive, high intracellular TROP2 expression in comparison to the membrane expression of TROP2, you can see you clearly enrich your population with a benefit with datopotamab deruxtecan. You reach median PFS around 7 months versus around 3 months in patients who are QCS negative. And if you look in the control arm with docetaxel, it does not influence the magnitude of benefit. So it seems to be predictive of the benefit of datopotamab deruxtecan, and also in terms of response rate, 32% versus 16% in the QCS negative that receive datopotamab deruxtecan. What about in the most interesting population of interest, non-squamous, non-AGA? You have exactly the same magnitude of benefit. You might select the patient that have the best prognostic, the best efficiency of datopotamab deruxtecan. It's a PFS, it's not OS data, but you can see you reach 7.2 months median PFS QCS positive versus only 4 months, I would say, in the QCS negative. And in the cohort control arm with docetaxel, same magnitude of benefit, around 4 months median PFS. So potentially the patients who are QCS positive, they derive the best benefit to receive datopotamab deruxtecan. Clearly, this is something that needs to be confirmed and currently included in most of the prospective trial ongoing with datopotamab deruxtecan. And you can see also, if you look the proportion of patients who have QCS positive, it's clearly higher in the non-squamous, between 60 to 70% of patients QCS positive versus the non-squamous, only 44% QCS positive. That might explain why the squamous have a less benefit to receive datopotamab deruxtecan versus non-squamous. So potentially nice biomarker to be confirmed in the prospective randomized trial currently ongoing. So that means nowadays, what we can say, according to the prognostic role of TROP2, it seems to be a worse prognostic, particularly in the non-squamous, not completely confirmed, but keep in mind generally a much more aggressive disease. The TROP2 expression might vary according to the actionable genomic alteration and particularly the EGFR mutation. It seems that in this population, you have a higher expression of TROP2, and we have some data to say that this population previously exposed to EGFR TKI, including osimertinib, might overexpress, might activate the TROP2 expression, which makes sense after to block the TROP2 with datopotamab deruxtecan. The intracellular TROP2 expression seems to be related to more resistance and less sensitivity to immune treatment. This is something important, which might make sense also. So that means nowadays we combine datopotamab deruxtecan plus immune treatment in first line in this population with an activation of the TROP2 with a high intracellular TROP2 expression. They might be more resistant to chemotherapy, so it makes sense in this case to combine datopotamab deruxtecan plus immune treatments. Let's wait the trial ongoing. What about the biomarker? Biomarker, for sure, we need to discuss about the fresh tissue biopsy. It's always the issue. If you perform biomarker on archival tissue biopsy, the patient previously received multiple lines of treatment, you might fail to demonstrate any benefit on archival tissue biopsy. So the rebiopsy is really something important that we have shown in the ICARUS trial. And you have seen this new biomarker, digital biomarker, the QCS, that might evaluate cell by cell the ratio membrane and the cytoplasm of the TROP2, might seem to be currently the most interesting biomarker to be predictive of the benefit of datopotamab deruxtecan, but which need to be validated in all the prospective currently randomized trial. Should we use in clinical practice tomorrow this biomarker to select patients to receive datopotamab deruxtecan? I hope yes, because you have seen the data. It seems to be really predictive of the magnitude of the benefit, activation of the receptor, not only the expression on the cell surface. And so I think this is what we can say nowadays about the TROP2 expression. Thank you so much.
Thank you. So thank you for your both excellent presentations. I think we can start from the last question. So, and there is a nice question from the floor, and they say, how does multidisciplinary collaboration play in managing the toxicities in the TROP2 ADCs? So if you, I think we are just in the beginning of this study, so if you have recommendations on how to manage the different toxicities, because we have seen that the Dato-DXd is totally different from sacituzumab govitecan. So yeah.
I suppose from a Dato-DXd perspective, certainly one of the toxicities that is of note is stomatitis. And we have seen that patients who take a steroid mouthwash in conjunction with this can really, upfront, can really help with this. So I think obviously educating ourselves, becoming familiar with this as oncologists, but also having a multidisciplinary team with strong nurse specialists, those who might be specialists in oral care and others to help us if it's a very complicated area is certainly something that can be helpful. And in terms of the ADCs, that's probably the one that sticks out most for me. What do you think, David?
No, I totally agree. So that means all this type of toxicity, we need to anticipate, and I think whatever the type of treatment, and we have mainly like chemotherapy-like toxicity, so do not forget that finally you have this toxicity in terms of hematological toxicity, GI toxicity, so we know how to manage this toxicity with the chemotherapy, so it's not targeted treatment, it's targeted chemotherapy, but we still have this payload and the issue of toxicity, so you need to anticipate this type of toxicity. After you have this specific toxicity depending on the ADC, depending on the payload, and for sure you have these mucosities with datopotamab deruxtecan, and you need to anticipate. Again, don't wait to have a grade 3 and grade 4 or grade 2 toxicity, otherwise it might be an issue. So anticipate by mouthwashing with corticosteroid, what we do nowadays before to start the treatment. And if you see nevertheless an improvement or an increase in terms of toxicity, probably you need quite quickly to stop the treatment, decrease the dose level, as we manage with chemotherapy. We have the other toxicity with sacituzumab govitecan, the GI toxicity. You have also some other ADC with the neuropathy toxicity, the eyes toxicity, the ILD toxicity. So anticipation is probably the best way. And I would say, for me, the best recommendation is always in this case, don't hesitate to stop the treatment, postpone the treatment, and decrease the dose level. And generally, just the fact to go -1 dose level, it goes better. Don't try to push as much as possible, otherwise it might be difficult for the patient.
I agree, and there is another particular toxicity that is the ILD. And we have seen also with other antibody-drug conjugates, what is your, when you see the CT scan that is showing a possible ILD, what is your recommendation? Do you involve other people? Do you do a bronch? So I think that this could be really important again.
Yeah, I think there's been very good work, to be fair, done in generating data on the ILD that occurs from the ADCs. I think we've all learned from our experience with IO and now helped with that. So a lot of these clinical trials have had independent adjudication committees for ILD to help to truly discern the grade that incorporate both a medical oncologist, a radiologist, a pulmonologist, and others. I think here the mechanism of the toxicity is fundamentally different to some of the other ILDs that occur. I think this is direct toxicity from the treatment in this case. So usually, you know, we treat very similarly to others. In a symptomatic case, we will give corticosteroids. There are standard protocols for this. In grade 1 cases, most of the time we will hold, and exactly as David said, you know, try to adapt accordingly. Don't try to push through necessarily in these instances. Because it is quite a specific pattern that we see sometimes, I often have not needed to do the bronchoscopy in this instance. I think I probably see that a little bit more with IO, ILD, where we see some strange infections and things which necessitate the bronch. Haven't really had to do the bronch as much in the context of ADC toxicity. I think it's always useful, though, to involve a pulmonologist. Obviously, there's functional deficit that can occur from this, to do PFTs, to think about doing a 6-minute walk test alongside simply the radiographic appearances. We know as well that resolution of ILD often can happen radiographically much later than clinical resolution. So monitoring things like a 6-minute walk test, oxygenation, these measures of function can often tell you that the lung has recovered more than the CT scan. So there are some really excellent algorithms that help with this. There was an excellent paper from Sandra Swain and colleagues on TDXD ILD, for example, that annotates all the different radiographic subtypes, how we approach these. And I think this can probably be used as a backbone for how we think about that. Anything else you would do?
I think it was complete. No, I'm totally agree. So I mean, we always have this network. We have this network for the HIO, for example, with dermatologists, neurologists, pneumologists, and so on. So I think for the ADC, we can use this network we already use, particularly for the pneumologist and to have the advisor. And in this case, for sure, we discuss in tumor board the CT scan, what to do, can we continue, can we make a specific evaluation, bronchoscopy, and so on. So this is something to take care of. And we have to take cautious, but because there is some ADC which are much more toxic on the ILD, for sure, with trastuzumab deruxtecan, better when you decrease the dose level, lower incidence if you for the anti-TROP2, for example, in terms of ILD. Yeah. So we need to look at, we need not to be too much stressed by this, because otherwise, sometimes, you know, it might be only infectious, it might be the disease. So don't stop the treatment for anything that appear on the CT scan. Otherwise, you might avoid the treatment. You might stop too much of the treatment. So be cautious.
I agree. I see also an over-reporting of the ILD in my patients, because now the radiologists are aware that the ILD potentially can come. So anytime that they see a sign of anything, they report the ILD. So I think that it is possible that we will have an over-reporting, and the multidisciplinary team with the radiologists and the pulmonologists will be crucial to determine what is just something different and what is ILD. So there are other questions here. Let me see, there are many. So there is a one that is, what about the actionable genomic alterations other than EGFR? Do we have data about their predictive value?
So we went through a little bit of the data in part of the presentation. Certainly a small number of patients with ALK-rearranged lung cancer has been explored in the context of some of the ADC compounds. I think far less data actually in the non-EGFR population. So something I think we can generate more data on. In ALK, I think there's an embarrassment of riches with respect to many of those treatments, and many of them are very well tolerated. So I think that's a different space, and there might be a different calculus with respect to what may or may not be the appropriate way forward. So I think ALK is one. Obviously, in the non-AGA space, a lot of those trials may have included KRAS. So there may be some of those, patients that are embedded in those clinical trials, and there are certainly efforts ongoing to understand the role of ADCs in that population.
I would say it's probably a good population of interest, except of the EGFR mutated population. In the ICARUS trial, we included some patients with a KRAS mutation and also some patients with BRAF mutation, and they had a drastic tumor shrinkage. So clearly, there is a signal of efficiency. I would be prudent for the HALK because for sure the magnitude of benefit was lower in the tropion pan tumor. but why not to have extension data on this population? But I think for the CARAS, probably for the BRAF and so on, we need to generate some data. And there is not only the TROP2 ADC, there is some ADC of interest. So I think we should not exclude this population post-TKI to be exposed to the ADC.
Yeah, thank you. And I would go back again to the biomarker. So I'm trying to pull some question from here. So tomorrow morning, you have, thinking that you have 3 TROP2 ADCs. Do you test for TROP2 with immunohistochemistry? When do you use the QCS? Is the QCS helpful also in the squamous histology? Is helpful also in the EGFR mutated patients? Can help to select other ADCs? So tomorrow morning you are in clinic, you have everything available. Clearly with the data that we have now, what is your algorithm of diagnosis and treatment?
So from my perspective, we don't yet obviously use the TROP2 IHC or QCS as a standard approach clinically. Obviously, your presentation at World Lung last year and then some evaluation from investigator-initiated cohorts has shown that this could be a biomarker of the future. And we will have to operationalize some of that. Obviously, that was done in a sort of computational fashion using digital pathology. I think many centers will then, need to be able to incorporate some of these methods. So right now, not yet ready for prime time, but I think something we are keeping a close eye on.
I would say I'm quite convinced by the QCS, or just the fact that you're looking at the intracytoplasmic expression of the TROP2, the ratio, and particularly the way that the receptor is activated, the trafficking of the receptor, because generally what have been generated, even with other biomarker and even for the HER2, H3, if you only have the receptor, but which is not activated in this case, you don't have the huge efficiency of the ADC. And sometimes we have nice data for which with specific TKI, you might activate this receptor and improve the response to ADC. So combination with TKI and ADC makes sense also. So that's why I think QCS makes sense. This is something also we have already shown, and we will try to confirm in the Icarus trial, because we have this 100 sample of patients and to confirm that this is something of interest. So I think the dynamic of the receptor is probably much more predictive than only look to the receptor on the cell surface. So I'm clearly believing that the QCS and this ratio might bring a benefit. I would say nowadays, do we have the techniques? This is probably the issue. We don't have all the techniques in all the centers to perform this type of techniques. Should we do this technique centralized? It can be centralized because it is digitalization, but that's since an invest for all the different centers. So this is another issue. The things which is missing probably in the puzzle, it's to have the data on the overall survival also on the QCS, not only the PFS, and also to look the QCS on the squamous, particularly because we have the QCS on the non-squamous adenocarcinoma, the best population. But I imagine if you have the good right biomarker, also in the squamous, you have patients that might be QCS positive. I would be happy to see that in this population, QCS positive, you can demonstrate also a benefit of that topotemal deruxtecan, so to make it much more confident. So OS data, QCS also in the squamous to see if we can enrich this population. And for sure, that might be probably the biomarker to use tomorrow for this ADC.
Yeah. I think as well, QCS hasn't been evaluated in the EGFR mutant population.
Yeah.
So that is still a gap in our knowledge and something we should address.
Yeah. So the QCS was evaluated and was created specifically in the adenocarcinoma and with the progression-free survival as an endpoint. The reason why it was not tested in the EGFR is because the population was too tiny. So it was impossible to run the experiments on very few patients. But I think that there are trials that are ongoing now that are using the QCS as a stratification factor, if not as a primary endpoint of the trial. So we will see in the future. I just want to add one point that is important to remember, that the QCS NMR is important only for the antibody-drug conjugates that need the internalization of the receptor. For example, the sacituzumab govitecan doesn't need the internalization of the receptor. It is active just with a bystander effect. And so you don't have to think that the QCS can be useful for other ADCs. So this is specific now just for Dato-DXd. So I'm sure that maybe this will open a new era for other biomarkers in the field with a dynamic complex, but you can't translate the QCS for other ADCs. And then finally, I just want to add to your comment that it's true that not all the centers, they have a scanner, but I have a small lab of artificial intelligence in my hospital, and a scanner can cost $200. So just to tell you, that is really feasible. Yeah. And just for fun, in my lab, we created also a scanner that is connected with a little computer and can cost like $100, 100 euros. We are in Europe. So,
so we can do in consultation time.
Yeah,
we can put it in our clinic.
Yeah, just to say that now we think that is something for which you need a superpower, a bigger computer or something like that, but is much cheaper than what we really believe. So, and if you need help, I'm happy to answer a question. So we created this little computer for the developing countries, and it's really something that can be done very, very, very easily. I just go with the other questions. So I think that we didn't mention about the future clinical trials, but from the questions that I read, there is a lot of concern about for the toxicity, about the antibody-drug conjugates forever and ever. For example, in the first line, the trials are using the antibody-drug conjugates without a specific timeline. So are there trials that are evaluating also shorter courses, maybe combined with immunotherapy, or just we will use the antibody-drug conjugate until the patients will resist?
So far, I think exactly as the question says, most of the trials include indefinite treatment. And I think a little bit like the IO space, this is how the trials have been designed thus far. But we can't forget that ADCs are a form of chemotherapy, and we don't ever dose chemotherapy indefinitely. We only give 4 to 6 cycles of platinum doublet, and maybe some sort of simpler treatments we might give as maintenance. So I fully agree with the question, and I think that duration studies are certainly what we need and will be just as important in the next step of optimizing ADC.
Totally agree. I think probably we have this generation, and probably we have further generation, less toxicity, much more specificity, and so probably it will be much more convenient to continue. I think as we do with chemotherapy, I think probably we need this induction in combination with IO, and after probably the escalation, we might stop the ADC and continue the immune treatment. We have also the same question with a patient with an EGFR mutation, and we have the FLORA2 trial that shown the best benefit on the PFS, so that means chemotherapy plus osimertinib, and after you might stop chemotherapy and follow the osimertinib, you will have probably the same way to replace platinum-based chemotherapy with an ADC, osimertinib, stop the ADC and continue osimertinib as long as the patient responds. So I think you have the induction is probably the most important, and the things you have the chemotherapy effect, which is nice, but you have also all the immune effect of the ADC. We know it's quite complex, but depending on the Fc gamma receptor of the ADC, the ADCC, efficiency of the ADC and so on. So I think it makes sense probably after to stop the ADC and to have the prolongation of the benefit of the ADC.
Yes, I think that there are a lot of other questions, but we are running out of time. So do you have one final comment, each 2 seconds, or a recommendation to give to the people on the floor?
I think ADCs are an exciting class of compound. I think some of them have already some early approvals. Certainly we as the clinical community will need to become familiar with how to give these treatments and watch the space as to where the different ADC compounds may land. They may represent a range of the different types of patients we see in thoracic oncology.
I would say probably for the ADC that target TROP2, it's not the end, it's just the beginning. Despite we have been disappointing by the phase 3 trial negative, but that just finally learning that we don't need to launch phase 3 trial with no biomarker, and particularly for the pharma. So it just to remind nowadays in 2025, we need to generate huge data, clean data, phase 1, phase 2 clinical trial, highly select patients, and generate hypotheses and perform the phase 3 trial on highly selected patients. So that means nowadays we cannot treat all the patients on the same way and expect to have a positive trial. It's not over. So we need to select patients and increase for the patient with the ADC that target TROP2.
Yeah. So thank you. It was really an excellent discussion. I just want to summarize that TROP2 antibody-drug conjugates are emerging as novel class of drugs with a distinct mechanism of action, offering potential benefits for certain patients with advanced metastatic non-small cell lung cancer. They are associated with a particular adverse event profile, and more research is required to establish the optimal usage strategies to enhance patient outcomes. And digital biomarkers are emerging as a new technology to understand who are those patients who really benefit of these drugs. Having said that, you can again scan the QR code to also have your credit and also to share your feedback. And I would like again to acknowledge all the people here on the floor, the colleagues on the floor, touchIME for the fantastic organization of the satellite symposium, and of course to the speakers and who were excellent. Thank you, and have a good lunch.